The following audio is part of a certified educational activity titled Making the Connection, a call to action against undiagnosed atrial fibrillation, improving detection, reducing risk. Access the entire activity and complete the post-test at www.peerview.com/NTH. Downloadable slides and practice aids are also available.
Hello, this is Dr. Christian Ruff from Harvard Medical School. Welcome to this on-demand learning platform on atrial fibrillation. After completing the activity, access the post-test and evaluation form by clicking the red Get Certificate button. I encourage you to download the slides, practice aids, and any other activity features that may interest you. Also, you can share what you learn in this presentation with your colleagues. To post this presentation via Twitter, Facebook, LinkedIn, or email, select Share this presentation from the menu at the upper left. Let's start with a case. Karen is a 70-year-old white female who presents for a routine follow-up appointment. Her medical history includes chronic kidney disease, hypertension, heart failure, and she reports having more than 8 alcoholic drinks per week. Her current therapy includes furosemide 20 milligrams twice a day, sacubitril valsartan 97 milligrams 103 milligrams twice daily, and carvedilol 3.125 milligrams twice a day, so a pretty standard heart failure regimen. Her blood pressure is 130 over 80 millimeters of mercury with a heart rate of 96 beats per minute. She has an estimated GFR of 50 mils per minute for some degree of renal dysfunction, and her BMI is 28.2 kilograms per meter squared. So, would you screen this patient for atrial fibrillation? This is an important question because it's estimated that there are approximately 3 to 6 million people in the United States with atrial fibrillation, and that number is expected to increase dramatically as the population ages. This is because atrial fibrillation is really a disease of the elderly and increases as people age, particularly in women since they generally outlive men. So more women are actually going to develop atrial fibrillation in their lifetime. This chart shows that the projected U.S. prevalence of atrial fibrillation in the year 2050 ranges from somewhere around 5.6 million to approximately 16 million individuals, so a really incredibly high number. This blue line shows estimates derived from the Anticoagulation and Risk Factors in Atrial Fibrillation study, which is really made up of cross-sectional data from a large California health maintenance organization. The orange line in the middle shows data estimating the number of individuals with atrial fibrillation in the United States through 2050. The investigators for this study identified cases of ECG-confirmed incident AF in Olmsted County, Minnesota, from 1980 to 2000, and used the U.S. Census Bureau data to estimate that the number of individuals with AF will reach 12.1 million by 2050. However, it's important to note that there was an increase in the age-adjusted incidence of AF in Olmsted County from 1980 to 2000. So for the same age, more patients were developing atrial fibrillation. If this is true, then the red line is actually a more accurate projection of the number of individuals with atrial fibrillation in the United States should this increase in age-adjusted incidence in AF persist. Here we see data from the Framingham Heart Study showing the relationship between AF and age. Men and women without atrial fibrillation at 40 years of age were determined to have a 26% and 23% likelihood of developing incident atrial fibrillation by 80 years of age. So a 1 in 4 chance if you reach the age of 40 of developing atrial fibrillation in your lifetime. The risk factors for developing atrial fibrillation are listed here and include advanced age, the biggest driver of atrial fibrillation, hypertension, heart failure, type 2 diabetes, vascular disease, and sleep apnea. For our patient Karen, she has advanced age, hypertension, and heart failure, which all contribute to an elevated risk of developing atrial fibrillation. So why is it important to screen for atrial fibrillation, particularly in these at-risk populations? We mentioned our aging population is certainly one important factor, but there are others, including these new screening technologies, which are allowing us to identify atrial fibrillation in many more patients. Also, we know that atrial fibrillation is a marker for stroke, and these strokes are preventable, and that treatment of AF has become much easier due to the advent of direct oral anticoagulants. We know that survival differs as well with the type of atrial fibrillation patients present with. This Kaplan-Meier curve shows all-cause mortality according to presentation with either typical atrial fibrillation symptoms, which are generally palpitations, or without other symptoms. Atypical symptoms are very frequent and include fatigue, chest pain, shortness of breath, lightheadedness, syncope, decreased exercise tolerance, but without palpitations, or completely asymptomatic atrial fibrillation, which really means AF that's detected incidentally during routine visit for a completely unrelated problem. In asymptomatic patients, AF can produce a variety of symptoms which are nonspecific, and many patients actually have no symptoms whatsoever. Unfortunately, the problem is stroke can often be the first presenting symptom of atrial fibrillation. In fact, in 15 to 20% of stroke patients, AF is actually found at presentation. Studies of patients with implanted devices like pacemakers or defibrillators confirm that some patients have strokes well before AF is even documented. The complications of atrial fibrillation can be thromboembolic, such as stroke and systemic embolism, which is basically a clot that goes somewhere else other than the brain, and hemodynamic factors, which include fatigue, shortness of breath, palpitations, and heart failure. We know that there's really a triad of changes that happen that increase the risk of stroke in patients with atrial fibrillation, which include abnormal changes in blood constituents, which increase the risk of clotting. There's also increased platelet activation and inflammation. There are actually important changes that occur within the vessel wall of the heart. So the lining of the heart, the endothelium, undergoes irreversible changes that predispose the surface of the heart to clotting. And of course, because of the abnormal heart rhythm, there's actually abnormal blood stasis, particularly in the left atrial appendage, that leads to left atrial dilatation as well. All three of these major factors predispose patients with atrial fibrillation to an increased risk of clotting within the heart. And if this clot forms within the heart and is injected, the first organ this clot will see is the brain. So let's review how stroke develops in patients with atrial fibrillation.
Atrial fibrillation can cause a heart to beat too slowly, too quickly, and irregularly. With atrial fibrillation, there is blood stasis in the atria leading to pooling of blood. This pooling makes it more likely that blood clots will form. Once a clot has formed, blood flowing through the heart can cause the clot to detach and travel through the circulatory system until it reaches the brain. The clot can then block the vessel and prevent the normal flow of blood. The surrounding brain tissue will be deprived of oxygen, causing stroke.
I find this video to be very helpful in helping patients better understand the link between stroke and atrial fibrillation. This graph shows the time to first episode of AF as determined in the REVEAL AF study. And what we learned from this is that the single time point screening may actually miss atrial fibrillation. And even short-term monitoring, say 30 days, is really not enough to detect atrial fibrillation. So let's move on to discuss screening strategies for non-valvular atrial fibrillation and the treatment of patients with this diagnosis. We'll begin by looking at where, who, and how to screen for atrial fibrillation. So there are various ways we can screen for atrial fibrillation in the general setting. The first and probably the easiest and what makes the most sense is in the primary care or specialist clinics, because that's where all these patients are going to be routinely evaluated, even for their routine yearly physical. There are other opportunities for screening, which include non-medical healthcare practitioners, such as pharmacists, or even general population through various venues, including the advent of new technologies. So whom to screen for atrial fibrillation? Well, we know that age is the biggest driver of atrial fibrillation, so the most comprehensive screening would be to screen people aged greater than 65 years of age. You could also screen younger patients, so those younger than 65, who have some other enrichment factor that predisposes them for atrial fibrillation. What types of factors would these be? These could be other risk factors that we know are related to atrial fibrillation, such as hypertension or diabetes, or even biomarkers. We know that there are different things we can measure in the blood in routine clinical care that actually predispose patients to developing atrial fibrillation. So both of these strategies could make sense for screening, although probably the easiest and the most comprehensive is just having an age cutoff greater than 65. Now, how do you screen for atrial fibrillation? Well, here this is a very rapidly evolving field. There are different strategies and they all have their pros and cons. There could be opportunistic pulse screening, then followed by confirmation with an ECG. There could be a single time point, so just getting a single lead ECG in a patient. Now, that's all on the physician side. There can be patient-activated ECGs, say 2 per week, in individuals who are 75 or above, or potentially a younger patient if they have other risk factors. And probably a very important population are those patients who've had a stroke that there's been no determined etiology. We call this ESUS, or embolic stroke of undetermined source. And we know that these patients may have underlying atrial fibrillation, so it's very important to have long-term continuous monitoring. There are various ways we can accomplish this. Patient-activated devices are really gaining a lot of momentum. One of the biggest is probably blood pressure or photoplethysmography, or PPG. Is there a benefit with opportunistic AF screening in the family practice setting? Importantly, can opportunistic AF screening be operationalized practically in order to facilitate screening in very busy PCP offices? Should systematic screening be done using electronic health records to find these patients and then send them a letter or call them to come into clinic for an appointment? Should patients greater than 65 years of age have an alert programmed in the electronic health record to ensure that they're opportunistically screened when they come in for a routine visit or for an unrelated issue? The European Heart Rhythm Association has actually proposed the strategy shown here. So they've done a very nice job of outlining how we'd approach atrial fibrillation screening, from palpating the pulse, maybe doing an automated blood pressure measurement, which will pick up on heart rate variability. There are now handheld ECG devices that can be used, or multi-head patch recording. There are different screening tools for atrial fibrillation, and they really vary from the most simple and basic to some really cool high-tech devices. Probably the easiest is just measuring the pulse, so sticking your finger on the radial pulse. But there are more advanced digital strategies. There's blood pressure monitoring, which can pick up an irregular pulse. There are patches that patients can wear for several weeks that may pick up an irregular rhythm or atrial fibrillation. There are implantable devices that could be placed subcutaneously and left in for months to years. And actually, most exciting, there are smartphone-based devices that patients associated with an app can actually monitor their pulse and even get an indication that they may be in atrial fibrillation. And they even have FDA approval. And in fact, the sensitivity and specificity of these devices are actually quite good, ranging usually in the low to mid-90s. So these are very effective tools for screening the population for atrial fibrillation. It's important that no matter how these screening strategies are employed, they must be followed with an ECG for confirmation. That's really critical. Once there's a clinical evaluation of the 12-lead electrocardiogram that shows atrial fibrillation, then those patients can be appropriately triaged and managed, which would include referral for an echocardiogram, treatment of underlying heart disease, and of course, risk stratification from stroke, And if they do have documented atrial fibrillation, almost all of those patients will be started on an anticoagulant as well as have their rate or rhythm controlled for their atrial fibrillation. We want to look for key changes in EKGs that are indicative of atrial fibrillation. These really include the pathognomonic irregular rhythm. When you see atrial fibrillation, there's lack of any discernible P wave or atrial activity. Absence of an isoelectric baseline because there is no atrial activity that's reliable. Of course, atrial fibrillation, because of this chaotic atrial activity, leads to variable ventricular rates, the irregular rate part. QRS complexes are actually usually normal, so less than 120 milliseconds, unless there is a pre-existing bundle branch block, accessory pathway, or rate-related aberrant conduction. What's confusing is actually when patients first develop atrial fibrillation, you may see something called fibrillatory waves, which can either be fine amplitude or coarse amplitude, and it looks like they have some underlying atrial activity, but it's very chaotic and irregular. It's not the organized P waves of normal sinus rhythm. This is frequently found when patients are first diagnosed with atrial fibrillation. So it's important to note that fibrillatory waves may mimic P waves, leading to misdiagnosis. So it's really critical to look very careful to see whether there's organized atrial activity. Getting back to our patient Karen, let's look at her evaluation for and diagnosis of atrial fibrillation. Karen's pulse was recorded at 96 beats per minute, and her EKG showed the key changes we look for in atrial fibrillation, including an irregular rhythm, no discernible P waves, a variable ventricular rate, and a narrow QRS complex. Based on these findings, Karen's AF diagnosis was confirmed, and the question really now is, should Karen's AF be managed by her PCP, or does she need referral to a cardiologist for treatment? Primary care really seems to be the logical healthcare setting for the chronic management of patients with atrial fibrillation, since these patients are already seeing their primary care doctor regularly. However, primary care really has not yet played a dominant role in AF management, which has, in fact, been more fragmented between different healthcare providers, which include cardiologists and family medicine. This fragmentation might have contributed to higher healthcare costs. One approach is being evaluated in a really interesting all-in study. All-in is a cluster randomized trial that will evaluate structured, integrated management of patients with AF in primary care. What does integrated management mean? Well, it's characterized by case management of anticoagulation in the primary care setting, quarterly checkups for AF and its related comorbidities, and easy access consultation with cardiologists and thrombosis experts. There are 5 domains of integrated AF care, and that really includes treatment paradigms, so controlling the rate of atrial fibrillation and the rhythm. That's generally used with beta blockers or other nodal agents and may include cardioversion or other rhythm management strategies. Certainly managing precipitating factors, so that might be lifestyle changes, losing weight, treating the sleep apnea. Of course, assessing stroke risk is vitally important. We know once you develop atrial fibrillation, those patients are at an elevated risk of stroke and require lifelong oral anticoagulation to reduce that risk. Assessing the heart rate is important. We certainly want patients to have their heart rate well controlled, because being at an elevated heart rate for long periods of time could have deleterious effects on the heart. And of course, assessing symptoms. Do they have symptoms from the drugs we're using or the cardioversion? And if necessary, maybe we accelerate them down to other more advanced strategies, such as AF ablation or potentially even surgery. We do all of these things to have the desired outcome of achieving hemodynamic stability, a well-controlled heart rate, maybe sinus rhythm if we're able to manage that. But more importantly is reducing their cardiovascular risk, which primarily is reducing their risk of cardioembolic stroke, which is the most common type of stroke we see in patients with atrial fibrillation. We know also that controlling AF rate and maybe even rhythm has important beneficial effects on the heart. We do this because hopefully that will translate into patients feeling better, having an improved life expectancy. The American Academy of Family Physicians has actually recently updated their clinical practice guidelines for the pharmacologic management of newly detected atrial fibrillation. The first recommendation is a strong recommendation for rate control in preference to rhythm control for the majority of patients with atrial fibrillation. Preferred options for rate control, so slowing the heart rate, include non-dihydropyridine calcium channel blockers and beta blockers. Rhythm control may be considered for certain patients, and that's really predicated on patients who are still symptomatic despite rate control. So if they have decreased exercise tolerance or they have strong preferences to be in a normal sinus rhythm. The second recommendation by AAFP recommends lenient rate control, which is generally defined as less than 110 beats per minute at rest, over very strict rate control, which is less than 80 beats per minute in patients with atrial fibrillation. This is important because we used to be a lot more aggressive in rate controlling patients. I will say, though, that that recommendation really is for patients who do not have impaired heart function. So patients with heart failure, with reduced ejection fraction, or symptomatic heart failure, it's still uncertain whether a lenient control strategy is ideal. The third recommendation is that clinicians discuss the risk of stroke and bleeding with all patients considering anticoagulation. This is certainly a very important shared decision-making point. Clinicians should consider the continuous CHADS-2, or probably actually the CHADS-2 VASC score for prediction of stroke, and to assess bleeding with the HAS-BLED score, which is the most common bleeding risk score used in clinical practice. When calculating the risk of AF, there are a few tools we can use, which generally started with the CHADS-2 risk calculator, which is basically 5 risk predictors for stroke in patients with atrial fibrillation. Because prior stroke or TIA is the most predictive for a stroke, actually that gets 2 points and the others get 1. So patients could have a range on the CHADS score of 0 to the highest being 6. The CHADS VASC score has really replaced the CHADS-2 score for stroke prediction in atrial fibrillation. It's a more comprehensive score. It includes all of the variables of the original CHADS score, but adds in some other factors that we know also predispose patients to the risk of stroke, including a younger age. So not waiting till a patient gets to 75 years of age, which now has 2 points in the CHADS VASC score, but including 1 point for patients aged 65 to 74. It's also added in a point for vascular disease, which is defined broadly for coronary disease or peripheral vascular disease, and adds a point for being female gender. Now, it's important to note that being a female only gives you a point in the CHADS VASC score if you have another factor. And so the CHADS VASC score is really the dominant risk prediction score for atrial fibrillation. So the most common bleeding score used out there is probably the HAS-BLED score. We know that unfortunately the HAS-BLED score does predict an increased risk of bleeding, but if you look closely at these risk factors, they're often the same ones that predict the risk of stroke, such as hypertension, prior stroke, age. So very frequently, patients who are at a high risk of stroke and require an anticoagulant are also at a higher risk of bleeding. It's important that most of the guidelines say that while you should assess bleeding with the HAS-BLED score, you shouldn't use an elevated HAS-BLED score to deny an anticoagulant to a patient at an elevated risk of stroke. So how do you use the HAS-BLED score? Really to look for modifiable factors that you may be able to change the treatment of that patient to lower their bleeding risk. Well, what do I mean by that? Say a patient has untreated hypertension. Well, if you treat the hypertension more effectively, you'll lower their bleeding risk. Well, what about if they get a point for antiplatelet drugs? Well, maybe the patient doesn't need to be on aspirin, and if you stop their aspirin, you lower their bleeding risk by 50%. So don't use the HAS-BLED score to deny an anticoagulant, but use it to look for modifiable risk factors to lower that patient's bleeding risk. If we look at Karen's risk scores for bleeding and stroke, we see that, like I said, she's at high risk for both stroke and bleeding. She has a CHADS VASC score of 4, a CHADS score of 2, and a HAS-BLED score of 5, so at a high risk of stroke and bleeding. Moving on to treatment, we'll start with recommendations based on the patient's CHADS-2 score. So if we look at the CHADS-2 score For a CHAD score of 0, the recommended treatment is not to provide anticoagulation because their risk of stroke is so low that their risk of serious bleeding with an anticoagulant would outweigh their risk of stroke. And for patients with a CHAD score of 1, the options could include aspirin or anticoagulation because their risk of stroke is high enough to warrant the potential bleeding concerns with antiplatelet or an anticoagulant. As I mentioned, patients at the higher risk of CHADs, so 2 to 6, really their risk is so high that we'd really want to recommend an anticoagulant because we know an anticoagulant is far more protective for stroke than antiplatelet medications such as aspirin. Anyone with a CHAD score of 2 to 6 would warrant an anticoagulant for life. With respect to stroke prevention, the American Academy of Family Physicians strongly recommends that patients with atrial fibrillation receive chronic anticoagulation unless they are deemed to be at a low risk of stroke, so a CHADS 2 score of less than 2, or have specific contraindications. Choice of anticoagulation therapy should be based on patient preferences and patient history. Options for anticoagulant therapy may include warfarin, apixaban, dabigatran, edoxaban, or rivaroxaban. So now patients actually have several options for anticoagulation. For over half a century, there was really only warfarin or other vitamin K antagonists. But in the last decade or so, there have been the introduction of 4 new drugs, which are part of the same class, which are called NOACs. They're originally novel oral anticoagulants or non-vitamin K antagonist oral anticoagulants. You'll also hear them referred to as DOACs, direct oral anticoagulants. They're all the same types of drugs. They're different from warfarin in several important ways. One, they don't require routine monitoring. So we know that warfarin really requires individual dosing and frequent monitoring of the INR. All of these drugs have very predictable pharmacokinetics, pharmacodynamics, and they don't need to be routinely monitored with a blood test. They're all rapidly active. So if you take one of these drugs, you're fully therapeutic in 1 to 2 hours, unlike warfarin, which often takes several days. Although you don't have to monitor the blood routinely to adjust the dosing, there are important factors to consider when dosing these drugs appropriately, the most important being renal function. All 4 of the DOACs or NOACs require dose adjustment potentially in patients who have significant renal dysfunction. Fortunately, these drugs have several other advantages compared to warfarin. There are not the numerous drug-drug interactions that plague warfarin therapy, and so they're much easier to use in elderly patients who have a lot of other concomitant medications. One of the questions that also frequently comes up is what do we do when we have to manage a bleed on one of these new DOACs or NOACs? Well, fortunately, there's been development of antidotes or reversal agents to potentially treat bleeding if it develops. There is one approved reversal agent for dabigatran, which is one of the DOACs, and we hope to have a reversal agent approved in this calendar year for the factor Xa inhibitors, which include rivaroxaban, apixaban, and edoxaban. So these DOACs or NOACs have all been studied in seminal phase 3 trials against warfarins for stroke prevention and atrial fibrillation. There are over 70,000 patients that have been randomized to one of these trials. And in a meta-analysis of these 4 trials, we see that as a class, the DOACs are more effective than warfarin in reducing stroke. You get an additional 19% reduction compared to warfarin. Now, this is pretty impressive because remember, warfarin reduces stroke by somewhere around 60 to 70%. So you're getting another 19, almost 20% on top of that reduction in warfarin. But by far, really where these DOACs shine are their safety. All of the DOACs, it doesn't matter which one of the 4, are associated with approximately a 50% reduction in hemorrhagic stroke, which is a bleeding type of stroke, and in fact in all types of intracranial hemorrhage, which includes subarachnoid hemorrhage, epidural hemorrhage. And so this is important because remember, anticoagulant-associated ICH has a mortality that approaches 50%. So the fact that these drugs, even without an antidote, reduce bleeding in the brain by 50% is a dramatic advantage. And because these drugs tend to be more effective and safer than warfarin, they're associated with a 10% reduction in all-cause mortality. In a meta-analysis of all observational real-world studies comparing apixaban with warfarin and other available DOACs, including 16 studies, it was shown that compared with warfarin, apixaban regular dose was more effective in reducing any thromboembolic event, but there was no significant difference for stroke risk. Apixaban was as effective as dabigatran and rivaroxaban in reducing thromboembolic events and stroke, and the risk of major bleeding was significantly lower for apixaban compared for warfarin, dabigatran, and rivaroxaban. Similarly, the risk for intracranial hemorrhage was significantly lower for apixaban than warfarin and rivaroxaban, but not dabigatran. The risk of gastrointestinal bleeding, which is actually the most common bleeding you'll see on an anticoagulant, was lower with apixaban when compared with all of the other anticoagulant agents. One of the other important things about real-world data that has emerged from some of the seminal studies is that, unfortunately, there has been consistent underdosing of the DOACs in the real world. What are the implications of underdosing? Well, first of all, let's try to understand why a physician would intentionally give the lower dose to a patient who didn't require a dose adjustment. Remember, dose adjustment is predominantly for renal dysfunction. So why would someone give a lower than expected dose? The general reason is to avoid bleeding in a patient the physician deems to be at high risk of bleeding. Well, what happens in the real world when this occurs? It turns out that actually these patients don't bleed less. So the whole reason for lowering the dose doesn't appear to translate to an increased safety advantage to using the low dose. But what is most alarming, that is inappropriate underdosing may be associated with a 4-fold increased risk of ischemic stroke. So this is very important because if you don't follow the label for dosing these drugs appropriately, you may predispose these patients to a significantly excess risk of ischemic stroke. And remember, almost a third of these strokes are fatal. This brings us to the 5th recommendation of the AAFP, which strongly recommends against dual treatment with an anticoagulant and antiplatelet therapy in patients with atrial fibrillation. And who are these patients? Which patients are going to require concomitant therapy with an anticoagulant and an antiplatelet agent? These are really patients who have coronary disease and have had a heart attack or required elective stenting. Most of these patients should be followed by a cardiologist, and I would recommend that these patients be jointly managed by both primary care and cardiology to effectively pick an antithrombotic strategy that reduces bleeding risks. Let's return to our patient Karen. Following her diagnosis, based on heart rate and EKG findings, an assessment of stroke and bleeding risk was conducted. The risk of stroke and bleeding was discussed with Karen, and she was engaged in shared decision-making with respect to the selection of a DOAC. A therapy was recommended for rhythm and rate control, comorbid conditions were assessed and addressed, and diet and lifestyle modifications were discussed. One of the things that we realized with all of this exciting clinical trial data and real-world data is that although the data is robust, that these new drugs, the DOACs or NOACs, are highly effective and much safer than warfarin, translating that into routine clinical practice is actually challenging because the clinical trial really doesn't tell physicians, particularly primary care providers, how to manage these drugs when they're seeing a patient in routine practice, how to dose the drugs, what to do if they need surgery, what happens if they have a bleed or get a stent for a heart attack. All of these practical questions come up all the time, and there's no single resource that had been developed to guide physicians and patients how to manage atrial fibrillation along the many months to years that these patients will require anticoagulant therapy. One of the important initiatives by the North American Thrombosis Forum, the NATF, which is a nonprofit organization of physicians and patients, was actually an AF initiative which gathered expertise across all of the medical domains: cardiologists, emergency room physicians, hematologists, gastroenterologists, neurologists, primary care physicians, and gather them all in one place to create a guidance document that really focuses on what are the practical issues involved in caring for a patient with atrial fibrillation. And so a physician doesn't have to look at 6 or 7 different guidelines or consensus documents, that they could have a single document or reference that they can use to consult for all of the variety of things that will happen to this patient along their journey with atrial fibrillation. So we hope that this practical guidance document is very helpful for physicians to have a living resource that helps them management of their patients with atrial fibrillation. So in conclusion, subclinical AF is very common. This is particularly true in the elderly and those with AF or stroke risk factors. So population-based screening may prevent stroke, but that really depends on the implementation, acceptance, economics, and different populations, tools, and strategies that are currently being tested. Finally, management of atrial fibrillation should include assessment for anticoagulation, that's really the most important, but also rate or rhythm control and treatment of underlying or associated diseases. That ends our discussion for today. I hope you found the activity informative and useful to your practice. Thank you very much for participating. And to take advantage of the next step of our educational curriculum, please click the Request a Meeting link in the activity menu, and we will schedule a live interactive session at your AAFP State Chapter meeting.
This activity has been jointly provided by the University of Florida College of Medicine and PVI, Peerview Institute for Medical Education. The activity is also co-provided by Medical Learning Institute, Incorporated. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/NTH. This activity is supported by an educational grant from the Bristol-Myers Squibb and Pfizer Alliance.